thoracoscopic, and open segmentectomy. How does segmentectomy compare versus lobectomy? In the 1990s, the lung cancer study group studied 276 patients with early-stage lung cancer in order to determine the benefits of lobectomy versus segmentectomy or wedge resection. In this study, limited resection was associated with a 75% increase in the recurrence rate, a 30% increase in overall death rate, and a 50% increase in cancer-specific death rate. This graph shows the significant difference in recurrence-free survival. Although overall survival was not significant, there is a clear trend toward improved survival with lobectomy. This study defined the role of lobectomy in the management of early-stage lung cancer. What are the oncologic indications then for segmentectomy? Certainly, segmentectomy is considered adequate for pulmonary metastasis when wedge resection alone is not adequate due to the central nature of the tumor. But what about for primary lung cancer, based on the parameters of tumor size, tumor margins, and CT characteristics? Okada and colleagues studied a large series of patients with early-stage lung cancer, comparing segmentectomy and lobectomy and analyzing survival based on tumor size. In patients with tumors less than 30 millimeters, segmentectomy was associated with acceptable survival. In patients with tumors greater than 30 millimeters, however, lobectomy was associated with a 5-year survival of greater than 81%, whereas segmentectomy was associated with survival less than 63%. The disease-free and overall survivals are demonstrated based on tumor size. Specifically, for patients with tumors 21 to 30 millimeters, there is an important difference between lobectomy and segmentectomy versus wedge resection. But in tumors greater than 30 millimeters, there's a difference between lobectomy and segmentectomy, as well as between segmentectomy and wedge resection. The authors then concluded that lobectomy or segmentectomy was appropriate for tumors less than 30 millimeters, but only lobectomy should be considered for patients with tumors larger than 30 millimeters. So tumor size, stage, age, and male sex adversely affected survival. For patients with tumors less than 20 millimeters, the authors concluded that segmentectomy was adequate. For tumors 21 to 30 millimeters in size, further study required, and for tumors larger than 30 millimeters, lobectomy only. This concept was supported in a multi-institutional trial of similar design, comparing 5-year survival for patients with peripheral tumors less than 2 centimeters in diameter, demonstrating equivalent survival with either sublobar or lobar resection. This study, by Nakayama et al., studied the role of CT findings on the outcomes with lobectomy or segmentectomy. They classified tumors according to the tumor shadow disappearance rate on high-resolution CT scan, differentiating the air-containing type with the solid density type. This demonstrates the air-containing type, where the tumor almost disappears on the mediastinal windows compared to the lung windows, whereas on the solid density type, the tumor is still readily apparent on the mediastinal windows. In this study, 38 out of 46 of the tumors were BAC, or non-invasive adenocarcinoma. No patient with air-containing tumors had recurrence with a median follow-up of 70 months, and the 5-year survival of those with air-containing tumors was significantly higher than those with solid density tumors. So to conclude, lobectomy versus segmentectomy. Segmentectomy may be considered in selected patients with tumor less than 2 centimeters, or those with ground glass opacity or air-containing tumors, which are frequently found to be adenocarcinoma in situ, as well as with specific patient-related characteristics such as advanced age or poor performance status or poor pulmonary function, especially when tumors are in the lower lobe. What is the value of thoracoscopic segmentectomy? One of the first series on thoracoscopic segmentectomy was published by Atkins et al. In 2007, and in this study there were 77 sublobar anatomic resections, 29 of which performed by thoracotomy or open segmentectomy, and 48 by thoracoscopy or thoracoscopic segmentectomy, defined as no rib spreading, and in all patients, complete hilar and mediastinal lymph node dissection was performed. This is a typical patient with a relatively central tumor with features consistent with bronchoalveolar carcinoma. Patients with central pulmonary metastasis. Patients with relatively limited lung function, such as in this patient with destroyed right lung due to bronchiectasis and previous surgical resection on the right. This slide demonstrates the Duke approach to thoracoscopic resections using a 1 to 1.5 centimeter incision in the 7th or 8th intercostal space and a single 4 to 5 centimeter incision in the 5th intercostal space for instrumentation and specimen removal. In this study, there was no difference between the pathologic stage of patients that underwent either open or thoracoscopic segmentectomy with non-small cell lung cancer. The following segments were the most commonly performed segments: superior segmentectomy, basilar segmentectomy, lingulectomy, lingular sparing left upper lobectomy or trisegmentectomy. There was no difference in operative time, estimated blood loss, number of nodal stations sampled, or chest tube duration, but there was a significant improvement in length of stay in the thoracoscopic group. No differences in mortality, the incidence of atrial arrhythmias, bleeding, or prolonged air leak were noticed. No differences in either local, regional, or distant recurrences were noted either, demonstrating the equivalent oncologic potential for thoracoscopic segmentectomy. One way to demonstrate the segmental fissure line is to partially reinflate the lung after the segmental bronchus has been stapled, yielding a difference between completely atelectatic and partially reinflated lung. Other methods have been described, including the opposite technique, that is selectively insufflating the segment of choice using a bronchofiberoptic technique, followed by either stapling or cautery cutting along the segmental fissure line. Other methods have been described, however, including the use of infrared thoracoscopy. In this pilot study, the dominant pulmonary artery was identified on the reconstructed CT and injected with indocyanine green. Thoracoscopically, with infrared visualization, a dramatic transition can be seen between the affected segment and the remainder of the lung. Other techniques include 3D multi-detector CT simulation. In this study of 50 patients, once again, the dominant pulmonary artery was identified, and selected simulated images were used to identify venous branches in the affected segment for division as well as preservation. Another technique using thoracoscopic technology and a super selective segmentectomy for deep and small pulmonary nodules under the guidance of 3D reconstructed CT angiography. So what then is the value of thoracoscopic versus open segmentectomy? The critical outcome advantages of thoracoscopic lobectomy are the incidence of fewer complications, the better compliance with adjuvant chemotherapy, and the ability to apply the technology in high-risk patients, either physiologically high risk or oncologically high risk. It is reasonable to assume that similar advantages would be associated with thoracoscopic sublobar resection as well. This study was one of the first to demonstrate outcome advantages of VATS versus thoracotomy. In this study, propensity matching was used to compare patients that underwent either open or thoracoscopic resection, demonstrating a much lower complication rate, 49% in open versus 31% in VATS, as well as lower complication rates of all the individual complications measured in this series. These findings were validated in a larger series using the STS database, a multi-institutional database, but with similar findings. A lower complication rate for the VATS patients, 25% versus 35%, as well as a lower incidence of all the measured complications in this study. The value of minimally invasive surgery is further supported in a recent systematic review and meta-analysis. In this study, there was no significant difference in local regional recurrence, but there was a reduced systemic recurrence rate associated with VATS lobectomy, including an improved 5-year mortality rate. From this forest plot, you can see that all-cause mortality is favored by the VATS approach, and And this concept was again supported by another analysis of matched and unmatched patients. The three matched studies, those with propensity analyses, are listed here. In this study, the relative risk of perioperative morbidity was superior in both the unmatched and matched groups, as well as the relative risk of all-cause mortality. This explains the increased use of thoracoscopic lobectomy as measured in the STS database over the past 10 years. In 2001, less than 10% of those lobectomies reported in the STS database were performed thoracoscopically, whereas by 2010, 45% of lobectomies have been performed thoracoscopically. In terms of technique for the basic lobectomies, for the left upper lobe lingular sparing lobectomy, it is advised that the vein to the left upper lobe is first transected, followed by the dissection of the anterior and apical arteries, and finally division of the bronchus and the parenchyma. For lingulectomy, the vein is divided first, followed by the division of the bronchus and then the artery, followed by the opening of the pleura and the division of the parenchyma. For superior segment of the lower lobe, it is most often performed by dividing the vein first and dissecting the bronchus from posterior under the bed of the dissected vein, and then the artery, and then the fissure and parenchyma, although alternatively the fissure can be opened first, followed by the division of the artery, then the bronchus, then the vein. Finally, for basilar segmentectomies, dividing the vein, followed by opening the fissure and division of the selected artery and the bronchus. For the anterior segment, it is advised that the vein is divided first, followed by division of the anterior arteries and then the bronchus. For the posterior segment, opening the fissure to identify the artery, then the intersegmental vein, and then the bronchus. For others, the middle lobe can be subdivided into two segments, and individual basilar segments may be divided, although these are more technically challenging. Other options to thoracoscopic segmentectomy are under investigation, including uniportal segmentectomy and robotic segmentectomy. These techniques use the same minimally invasive strategies and are thought to be associated with similar outcomes, with no evidence of superiority of either of these techniques over thoracoscopic lobectomy. What are the potential advantages of the robot? Articulated instrumentation may improve dissection in small spaces, and three-dimensional visualization may certainly improve dissection under difficult circumstances. The robot is also associated with motion scaling, which may reduce surgeon's tremor. But the outcome advantages are similar to thoracoscopy, and there are no specific advantages versus thoracoscopy. As far as the uniportal approach, this is becoming more and more popular worldwide, based on the experience in A Coruña, where the largest volume of uniportal resections are performed. This was the seminal study identifying the outcomes of the first 100 patients with a low conversion rate, a reasonable operating time, and a low length of stay. So in summary, thoracoscopic segmentectomy is recommended for selected patients with tumors less than 2 centimeters, specifically those with ground glass opacities, as well as other risk factors such as advanced age, compromised pulmonary function, or poor performance status. In general, it is thought that the surgical margin should be greater than the tumor diameter, and in published series, thoracoscopic segmentectomy is oncologically equal to open segmentectomy with fewer complications.